going to be going over chapter 24, which is your abdominal pain and your GI disorders. Now, when you're doing a physical exam, you want to look at what area of the abdomen is having pain. If you will, imagine that the abdomen is divided into 4 quadrants. You've got 2 lines that kind of intersect at the umbilical area. And this is going to make it a little bit easier to figure out what could be the possible underlying conditions or problems that could be causing issues. All of our organs are going to be classified as either solid or hollow. So some of our solid organs, for instance, would be like your spleen, your pancreas, something like that. When injured, those solid organs tend to bleed. They tend to fracture and bleed. Your hollow organs, that would be like your stomach, your intestines, things of that nature. When those are injured, they tend to rupture and spill their contents, which in the stomach's case is pretty bad because it's like basically hydrochloric acid being released into the peritoneal cavity. So here's just a visual of the kind of how it's divided up. Now mileage varies, depending on the patient and how big or small they are, that kind of stuff. With your GI tract, it is essentially one long tube from top to bottom. And then you've got your accessory organs that are going to connect in with it that do extra things. Alright, with the abdominal cavity, we do have some large blood vessels. So important to realize that bleeding can happen. You can lose a large quantity of blood. The bad thing is you can lose a large quantity of blood into the abdominal cavity before you ever see any external signs. You could lose enough to put somebody solidly into shock. So this is one of those, anytime you suspect they're showing signs and symptoms of hemorrhagic shock, but you don't see any bleeding, consider bleeding into the peritoneal cavity as a possibility. Alright, now food goes in, of course, to the mouth. We chew it up. It goes into the stomach. It's broken down, hydrochloric acid and pepsin. It turns into chyme, and then it enters the small intestines where nutrients are absorbed. Then it makes its way to the large intestines where the extra water is absorbed, which produces our solid fecal mass. Alright, this is why if you have diarrhea, it's very watery and thin. It's because it's moving too quickly through that large intestine and not enough water is getting absorbed out. If you have constipation, then it's moving too slowly through those large intestines and you're absorbing too much water, which makes it hard to move through. Your accessory things here, your salivary glands, these are going to secrete saliva into the oral cavity, help moisten, start breaking down the food. Your liver is going to process your nutrients and medications, detoxify things. Your gallbladder is going to store excess bile and release it to mitigate the fats that you eat. Your pancreas is going to do your endocrine and your exocrine functions. It's going to help regulate your blood sugar, among other things. When we are looking at an abdominal assessment, you have to understand there's a lot of organs, a lot of structures, and a lot of body systems that are all involved in the GI, or in the abdominal area. Some of your more common gastrointestinal related issues that you may see or hear about: nausea, vomiting, diarrhea, constipation, back pain, especially from that retroperitoneal place with kidney problems, things like that, bloating, anorexia, jaundice, hematemesis, melena, hematochezia. There's a lot of different things that can cause somebody to seek further care for the abdominal issues. Now, as far as your possible sources of pain, okay, so right upper quadrant, we're looking at possibility of liver and gallbladder. Epigastric region could be the stomach, could be pancreas, could be an acute myocardial infarction. Your left upper quadrant, spleen, part of your pancreas, your umbilical area or hypogastric area, your small intestine, large intestines, bladder, the uterus, the aorta. Your right lower quadrant, you've got your appendix, your ascending colon, the ovary and fallopian tubes. On the left lower, you've got your descending colon, and this is usually where you have diverticulitis issues, if they have diverticulitis. So, some things. If you have a problem with the liver, generally you'll have a kind of a steady dull pain in that right upper quadrant. You bleed more frequently, and they may have a jaundice. With hepatitis, tends to have flu-like symptoms and an enlarged tender liver. With cirrhosis, they tend to develop ascites, which is that fluid buildup in the abdomen, and you get shortness of breath from a liver enlargement, and that ascites kind of compressing on the diaphragm makes it hard to get a good breath. For gallbladder, if you have a gallstone that's blocking the bile duct, you get a crampy, colicky pain, usually within about an hour after eating, especially if it's a high-fat meal. Alright, you may have some right upper quadrant pain that radiates to the right shoulder or the back. You may have some nausea and vomiting, which increases after eating. Your cholecystitis, which is your infection in your gallbladder, may also have a fever and jaundice. With your stomach, gastritis or peptic ulcer disease, you have a steady burning epigastric pain. You may have nausea and vomiting. You may have vomiting up of blood, hematemesis. And if you have a perforated ulcer, you'll show signs of peritoneal irritation as well from the gastric juices leaking out into the peritoneum. For your acute pancreatitis, sudden onset, severe, constant pain in the epigastric, and it may feel like it's boring through to the back. They'll often have nausea and vomiting, and usually severe vomiting, and they may be vomiting up with blood in really bad cases. For your spleen, if it's enlarged or irritated, you may have pain in that left upper quadrant, and it may be referred to the left shoulder and neck. If you have a ruptured spleen, you have a sudden intense pain that subsides, and then it will get worse and worse and worse, and they may have a syncopal episode and some orthostatic hypotension due to blood loss. For the large and small intestines, if you have gastroenteritis, inflammatory bowel disease, colitis, any of that stuff, you may have the crampy colicky pain. You may have some vomiting and diarrhea, some dehydration. With a bowel obstruction, usually has an intermittent pain that's going to increase in intensity and then become more constant. Okay, so with our scene size up, we're looking for anything that might give us a clue as to what the problem might be. Specifically anything that maybe cause a problem with us, but also some things that'll give us clues about with the patient. Okay? As far as your primaries, secondaries, of course your ABCs, nothing has changed there. The big thing is the C. You may not always have obvious circulatory issues, even though they may have some underlying life-threatening bleeds going on. So we got to ask about them. All right? We're going to check for orthostatics if it's applicable. We're going to look at the skin, see if they have any signs of paleness, coolness, poor perfusion, anything like that. We're going to look at the abdomen. Look at the abdomen, touch the abdomen. Feel the abdomen. Normal abdomen should be soft and non-tender. It shouldn't hurt when you touch it lightly. If it's painful, that's a problem. If it's distended and swollen, that's a problem. All right, get a good medical history. Ask about any nausea or vomiting or any pain, any lightheadedness. It's not comfortable, but ask about if they've had any blood in their stool, any dark tarry stools that smelled really bad, even worse than normal. Any changes in the urinary output, all these things, ask them about their poop. People don't like to talk about it, but ask them about their poop. It's important. All right. Anemia is one of the more serious complications of a chronic GI bleed, because if we don't have enough red blood cells, we don't have enough blood cells to transport oxygen, so we're going to become hypoxic. All right. With your abdominal pain patients, typically they're going to be a little more comfortable lying on the sides with their legs drawn up, kind of in a fetal position, curled up. The reason for this is it's going to release some of that pressure, that tension of the abdominal muscles on the abdominal wall, which can ease some of that pain. So if you can secure them with their seat belts in that position, let them, if there's no other reason not to, let them have that positioning if at all possible to minimize any pain and discomfort for them. Some of the things that can cause some problem: inflammation or infection, stretching of the tissues from distension. Now this one, you ever had a time where you feel like you got to go to the bathroom and you feel that little sharp stabby pain, you're like, ooh, and you run to the bathroom and you sit there for a little while and nothing happens, so you get up and you're like, alright, and you go about your business, and then a little while later you feel that same sharp stabby pain but a little bit different place? That's that colicky pain. That's basically a big poop moving through. And so this is that stretching of tissues. That should not be constant. Every now and then you may feel it, but it shouldn't be a routine, regular thing. And then you can also have ischemia. Now I know we typically to this point have associated ischemia with chest pain or heart muscle, but you can have ischemia of any tissue. And so if you have a blockage or torsion or anything like that of your abdominal organs, especially like in the intestines, you can have that tissue become ischemic, and when it starts to die, then that section of bowel dies as well. Alright, so a pain from an organ that is in the abdominal cavity that's difficult for the patient to localize. What do you think it is? Right. If you answered, too fast. If you answered visceral pain, you are correct. Alright, the pain from inflammation of the peritoneum that lines the abdominal cavity. What do you think that one is? Right. If you answered parietal, you are also correct there. Alright, pain experienced at a site remote from the affected organ that shares a sensory nerve pathway. What do you think it is? It is going to be referred pain. So with your visceral pain, this is from the organs, and it's difficult for the patient to localize. So this is the one where they're going to kind of move their hand around their abdomen. They're going to go, it just kind of hurts here, and they can't pinpoint to where it is. They just say, kind of move their hand around their abdomen and say, it here. All right, the parietal pain, this is from the inflammation of the peritoneum. This is usually a sharp, static pain, and this is usually where they can point to one area with one finger and say, it hurts here, it hurts here. This is a specific point that hurts. Now your referred pain is where you have basically that shared sensory nerve pathway where your body can't tell, is it your elbow or your shoulder? Is it your shoulder or your spleen? It can't really tell where that pain is coming from, so it may interpret that pain from somewhere else rather than the actual problem itself. All right, one of the biggest, kind of general, but one of the biggest cases you will see, that's one of the most life-threatening things you'll see with abdominal issues, is going to be peritonitis. And with peritonitis, this is inflammation of the peritoneal lining. Alright, your risk factors, ectopic pregnancy, perforation, abdominal surgery, a lot of different things. But your big keys here are going to be your high fever, nausea, vomiting, anorexia, and a rigid abdomen. If you have a rigid abdomen, that is a big flag for a life threat with abdominal issues. Alright, so let's talk some of the problems you'll see with... Let's talk some of the problems you will see with your abdominal issues. So you've got nausea and vomiting. Now, it's important to note, nausea, that is the symptom, right? We cannot see the nausea. We just have to trust that they have nausea. Vomiting is going to be the sign. That's something we can see and smell, and hopefully not, but we may feel as well, depending on how close you are. Now, there are a couple of different vomiting triggers. You've got one in your GI tract, which is more of like the food related, something's going on, it'll make you vomit. But you also have one in your brain or in some of your other organs that are more of a sensory nerve stimulation, and that trigger is not so much related to the GI tract itself, but this is the one that's more like you get motion sickness or something like that. Alright. Alright, with your disorders of the esophagus, there are quite a few different things that can cause an esophageal problem. One of the biggest ones you will see will be a hiatal hernia. And what happens is that you get the opening in the diaphragm actually enlarges a little bit, and so the top of the stomach actually slips up through the diaphragm, which causes a herniation of that stomach. My understanding is that this is extraordinarily painful. In fact, I know a paramedic that had this, and he thought he was having a heart attack. It hurt so bad. So this is not anything to be playing with. It can be very painful. It is more common with people who have acid reflux as well. Our treatment, there is no treatment for us. We're going to transport. We may not be able to tell in the field whether this is a hiatal hernia or whether this is an actual MI, depending on what's going on with the patient. So treat for worst case scenario, but just keep this in the back of your mind if you have a patient. This is more common after they eat as well to have a hiatal hernia development. And sometimes they'll slip in, slip out, back and forth as well. Now, some other issues that you will see, esophageal varices, or essentially varicose veins of the esophagus. They get distended, they get full, and they can rupture. And when they rupture, we're talking life-threatening bleeding. They will vomit up copious amounts of blood. I had a patient who had this, and in the 30-minute transport I had him, emergency, he lost approximately one full bucket. Now, you know those bedpans basically that we keep on the ambulance. He filled up one of those just about it with blood and stomach contents in that 30-minute transport. I'm not quite sure how he didn't die during that time. Another thing, esophagitis. Alright, so this is where you get inflammation of the esophagus. It's painful. In and of itself, not life-threatening, but can lead to esophageal varices or even a malarialized tear. Right, but this is from inflammation and eroding of the esophagus from acid reflux. This could happen if somebody's been vomiting a lot, if they're bulimic, if they had really bad GERD, acid reflux. Alright, your gastroesophageal reflux disease, or GERD, this is just a chronic acid reflux. They have medications, proton pump inhibitors, and other different medications to help minimize the amount of acid in the stomach to minimize the complications that can happen from it. Alright. As far as complications with your esophagus and or swallowing, so dysphagia And the way I remember it, pH in there, same as esophagus. So that was the one with swallowing, not speaking. But dysphagia is difficulty swallowing. Alright, and usually this is either mechanical obstruction or a motility disorder. But if they cannot move liquids or solids down the esophagus, then that puts them at a higher risk for aspiration and complications there, choking, that kind of stuff. Now, your dark tarry stool associated with a lower GI bleed, what do you think it is? To me, it kind of looks like grape jelly in this picture, but definitely does not smell like it. Alright, so if you answered B, melena, you are correct. So a GI bleed is simply a bleed somewhere in the GI tract, and we're going to divide it up into upper and lower GI. So our upper GI causes would be like an esophageal varice, a Mallory Weiss tear, which a Mallory Weiss tear is where the esophagus basically becomes detached from the stomach. Usually leads to a life-threatening bleed. This is more common in chronic bulimics and severe alcoholism. Your stomach, if you have an ulcer, acute gastritis can cause some bleeding. The duodenum, you can have ulcers. Your lower GI tract, your jejunum, polyps, cancer, inflammatory bowel disease, the ileum, same thing, and the colon, same thing, plus diverticulitis, which are little pockets basically where food and bacteria can get kind of trapped and cause irritation there. So if you have a GI bleed, alright, if it's an upper GI bleed and it's coming out the bottom, alright, it's going to be dark and tarry. It's going to be called melena because it's had time to be digested. So it's going to not look like frank blood, bright red blood. If it is a lower GI bleed and it's coming out the bottom, it's going to be bright red and bloody looking because it has not had time to get digested. If they are vomiting and it's had time to get digested, then they may have what's called coffee ground vomit, and that is your partially broken down blood in the bile, basically. Alright, inflammation of the stomach and intestines due to the presence of a pathogen. What do you think it is? Right. If you answered gastroenteritis, you are correct. Alright, the pain associated with this abdominal emergency typically comes on suddenly, beginning around the umbilicus, but localizing to the lower right quadrant. What do you think it is? It is going to be appendicitis. B, appendicitis. Alright, so gastroenteritis. This is just inflammation of the stomach and intestines due to some kind of pathogen. There's a whole lot of stuff that it can be. Alright, it's just kind of a catch-all phrase. Your appendicitis, this is inflammation of the appendix. Diverticulitis, this is an infection of the diverticulum. And your signs and symptoms are going to be very similar to your appendicitis, but instead of happening on the right side, they're going to happen on the left side in the descending colon. And then you've got your peptic ulcer disease. Now, for your peptic ulcer disease, they tend to cause your gastric ulcers. They may cause weight loss, they may cause pain, they may cause vomiting. Pain usually is going to increase after eating. They could also be caused by stress or things like that, but one of the most common is a bacteria called H. pylori. That is one of the most common risk factors for peptic ulcer disease. Smoking, increased alcohol consumption, and high levels of stress also increase your risk factor here. Alright, your appendix. Normal appendix, little thing hanging out there, inflamed, little red looking thing there, right? So your peak incidence is going to be the 10 to 12-year-old range. That does not mean that you can't get little bitty kids and you can't get adults with it, but it is more common in those preteen years. It usually starts as a dull, steady ache around the belly button area, and this is going to progress and localize to that right lower quadrant. They'll usually have a low-grade fever, nausea, and some anorexia. Now, if they have a sudden relief in pain, that may mean that the appendicitis or the appendix has ruptured, and now we're going to be headed towards peritonitis instead. A volvus or a torsion here. This is where you have a twisted portion of the small intestine, and when it does, it causes ischemia and it lowers or it blocks off blood supply to that affected portion of the intestines. This is a potentially life-threatening problem. Alright. A GI bleed, lower GI bleed, a lot of different things can cause it. It could be a minor bleed. It could be a life-threatening bleed. The thing with the bleeds, it depends on how bad it is and how long. People's bodies are really miraculous, and they can actually make up for a lot of these, a lot of the bleeding if it's a slow bleed over a long period of time, and actually kind of get accustomed to a lower amount of blood. So they may, by the time you get to them, by the time it gets to that point, it may have become a life-threatening bleed just because of the length of time it's been going on. Alright, now your bowel obstructions, it could be a mechanical blockage or something's physically blocking it, whether it's a twisting, a volvus or something like that, or whether it's what they call a paralytic ileus, and this is where the nerve control, for whatever reason, is not working. And this is actually really cool. I've actually seen it in one patient that I've encountered. They do it with others, but they actually had an injury with a gunshot wound, and so they had an abdominal pacemaker that actually provided that stimulus for the peristalsis in the abdomen, which I thought was just really cool. I didn't know until that point that they could do that. But there's a lot of alternatives there. Now, with your bowel obstructions, the higher the obstruction, the quicker you see the symptoms. If it's very late in the bowels, they basically can get full of crap. Really, and it takes a little bit longer before they start seeing problems with it. Okay. I have seen a GI bleed or a GI obstruction so bad that they were literally vomiting up fecal matter. So, I mean, it can get to that point. Some of the more common signs you'll see, really bad fecal smells, abdominal distension, and with your bowel sounds, you may not hear them at all. Now, a hernia, this is just an opening in which tissue is protruding. It could lead to a bowel obstruction, it could lead to a avulsion, or a volvus. There's a lot of different things that can go along with this. The big thing is if it completely blocks off blood flow to the tissue that's come through the hernia. We're not going to poke it back through or anything like that. We're just going to leave it alone and transport. Now, inflammatory bowel disease. This is kind of an umbrella of diseases that includes like your ulcerative colitis, Crohn's disease, that kind of stuff. It does tend to run in families. It is more common in your late teenage to early adulthood years, and they do believe that has something to do with the immune system. Some of the more common signs and symptoms are your nausea and vomiting, abdominal pain, some distension, tenderness, the severe diarrhea, a low-grade fever when it flares up, bloody stool, weight loss, that kind of stuff. Okay, your ulcerative colitis. This is where that mucosal layer of the colon actually gets inflamed and develops ulcers, and it leads to real bad diarrhea, bloody stools, abdominal pain, weight loss, that kind of stuff. And constipation, infrequent bowel movements, small hard feces. Think like rabbit poop. All right, rabbit poop is no good. You need more fiber and more fluids in your life. All right, hemorrhoids. Hemorrhoids is where you have inflammation of the vessels right around the anus, and with this they tend to bleed a little bit. They're painful, kind of itchy, so they're more common after pregnancy, after delivery. Excessive pressure, you may develop them if you're having to work to defecate frequently, if it's hard for you to defecate for whatever reason. As far as our treatment, there is really no treatment per se for EMS. We're just comfort care. As far as swallowed bodies, most things are going to pass through the stomach and continue on until removal. Until they pass through, but just depending on what it is, it may require some kind of surgical removal, but we're not messing with that. We're just transporting and letting them know what's going on. Now, occasionally, you will answer somebody who has a foreign body in their rectum. All right, two most common scenarios here are going to be some sort of erotic activity and avoid detection from law enforcement. So for us, unless they're bleeding or something, you need to see if you need to stop bleeding. We're not examining this. We're not doing this. We're transporting them a position of comfort to be evaluated by the physician. We don't want to mess with any of that. A lot of damage can actually occur from things being in there, and we don't want to risk the possibility of that happening. Big thing here, if it's like drugs or something like that, if they put a baggie of cocaine up there and that baggie ruptures, then they get a large dose of cocaine into their system. So we have to be prepared, and it is good to know what it is so we can be prepared, but no judgment. Alright, patients with this abdominal emergency often describe intense pain in the epigastric region, which they describe to as boring through to their back. Which one do you think it is? If you answered pancreatitis, you were correct. Alright, so pancreatitis is inflammation of the pancreas and usually has a very intense, severe mid-abdominal pain. Has a very high mortality rate due to shock and sepsis. The most common factor or cause is going to be alcohol abuse. And what happens is erosion of the pancreas, leads to the blood vessels that get eroded, and then they hemorrhage. Alright, some of the causes of your pancreatitis: biliary, which would be more of like your portal stuff there, your livers and whatnot, your alcohol, drugs, hypercalcemia, hypertriglyceridemia, high triglycerides, we'll just say that. Alright, idiopathic, meaning it just happens. Sometimes people have bad luck. Trauma, and interestingly enough, a certain scorpion sting can actually cause it as well. Treatment for it: comfort measures, manage bleeding as you can, just like you would any other kind of GI bleed, and transport. Alright, liver disease. So hepatitis, you've got infectious and non-infectious causes. Most of them are going to be viral, but you can have medications, toxins that can cause hepatitis as well. Now, chronic hepatitis can lead to liver cancer and cirrhosis of the liver, which can lead to portal hypertension and ascites. Your patients with an acute hepatitis oftentimes will present with pain in their upper right quadrant of the abdomen, nausea, malaise, and fever. Your different types of hepatitis, your viral. You've got A and E, and these are hepatitis with a vowel, comes from the bowel. So this is a fecal oral transmission. There is a vaccine for A, but there is no vaccine for hepatitis E. Alright, so this is the one where people are defecating, wiping themselves, not cleaning their hands, and then fixing your food. That's pretty gross, right? Alright, hepatitis B is bodily fluids, blood, semen, and saliva. There is a vaccine. In fact, if you work in the healthcare field, you should have this series of 3, and you should get your titers drawn pretty frequently. Hepatitis C is from circulatory, primarily blood, but there has been some evidence potential for semen transmission as well. There is no vaccine. Up until recently, there was no cure, but they have recently discovered a cure if you have no previous treatment for hepatitis C. Hepatitis D is what they call a superinfection, meaning you don't get D unless you already have B. Alright, there is no vaccine, and it's transmitted through the blood. Your signs and symptoms: right upper quadrant discomfort, nausea, vomiting, anorexia, weight loss, dark urine, jaundice, fever, chills, lots of fun things, right? So we are treating symptomatically. Now, for your liver disease, cirrhosis is just a progressive disease. Basically, your normal tissue is replaced by scar tissue. Right? And scar tissue does not work as well, so they have altered metabolism of drugs, vitamins, and pretty much everything else that the liver normally does. Alright? Now, some patients who have liver failure may actually be a candidate for a liver transplant, which is really cool because they can actually do, this is where they can do a living donor. They can take a live tissue, a live portion of a healthy person's liver and actually put it in the sick person, and it will actually grow and regenerate and form, hopefully, a fully functioning liver. But they must take anti-rejection drugs forever. Right, inflammation of the gallbladder occurs from the presence of gallstones. If you answered cholecystitis, you were correct. Alright, your signs and symptoms here: nausea, vomiting. Severe cases, you may get a distended gallbladder and can cause peritonitis. One of the ways you can actually test for this is called a positive Murphy sign, but where you have them kind of lean back and have almost like a crunch where they bear down and raise their shoulders up just a little bit. And if you have tenderness under that right coastal margin, that's called a positive Murphy sign, and that is often indicative of cholecystitis or inflamed liver. So they may have jaundice, they may have nausea and vomiting, they may have anorexia, and what they call fat intolerance, meaning that the symptoms become markedly worse after eating a high-fat content meal. Your high-risk population are overweight white women with a history of at least one pregnancy, and Pima Indians and Hispanic populations tend to have higher incidences of development as well. Now, some other causes. Your pneumonia, can be referred pain to the upper quadrants. Your myocardial infarctions can give you pain in the epigastric area. Your spleen, your kidney infections, kidney stones, and then of course an abdominal aortic aneurysm can all give you pain in the abdomen, and these are not GI related issues. Alright, so your abdominal aortic aneurysm, or your AAA, alright, most common cause is your atherosclerosis, hardening of the arteries, and your most common risk factor: smoking, being male, being older, and having high blood pressure. All right, so some of those you can do something about, some of those you cannot. Now, it's very important that you know the anatomy, the physiology, and the patho as it relates to the GI and the GI system and the abdomen. There are a lot of different things that can cause abdominal pain, and we can't fix most of them. So we need to be able to recognize when there's a life-threatening problem so that we can transport the patient to a proper location for evaluation by a physician. While we're transporting, we're going to make the patient as comfortable as possible. If they have inadequate respirations or if they're showing signs of shock, we're going to give them oxygen. We're going to consider the need for fluid replacement. If it's a bleed, we probably don't want to give them a bunch of fluids. If they've had severe nausea and vomiting, we may want to consider some of the fluid replacement. All right, if you're not sure, contact medical control about the use of any kind of analgesia with patients with abdominal pain.